Madam, start, madam. Mute la இருக்கீங்க ma'am. Start, ma'am.
got it பண்ணிருங்க. இந்த ரெக்கார்டிங் வந்து இன்னும் அத got it பண்ணிருங்க.
Good evening, everybody.
Madam, start, madam.
Yes, good evening, everybody. It is a great pleasure and privilege to welcome you all to this.
Volume correct இருக்கா?
Volume. Good evening, everybody. It is a great pleasure and privilege to welcome you all to this hybrid CME, which we are doing for the first time here. It is an honor to do it along with Tiruvannamalai OG Society and TNFOG. I welcome the office bearers of TNFOG. It is my pleasure to welcome Dr. Priyanku Rai, who needs no introduction. And I welcome all of you to this session of PIH and PPH, which is a nightmare to all of us. Hope we are able to overcome these difficulties whichever we see. I hand over to Dr. Alamelu, who is my secretary.
ஐயா தமிழ் தாய் வாழ்த்து கொள்ளையா?
Chitraka, first CV, please. Radha, madam.
So Priya,
Sambat,
I
ma'am.
will take I will take the pressure to introduce Dr. Radha Madhavi. See, Dr. Radha Madhavi is the founder president of Tiruvannamalai OG Society and director of Raja Multi Speciality Hospital, and she is the joint secretary of TNFOG and member of Foxy, ISAR and IMS. And really thank Dr. Radha and Alamelu and the Tiruvannamalai team to join with the TNFOG to conduct this Magalir Nalam CME. See, this is an obstetrician's nightmare, PPH and PIH. So only this is done in night, I think. After the dinner, the PPH and PIH starts. So first, I invited Dr. Anjalakshmi madam to tell few words, and then Radha can introduce Alamelu.
Good evening, everyone. Thank you, Dr. Sambar. It is a great privilege for me to give this welcome address for a very important CME, that is the nightmare to the obstetricians, the PPH and the PIH. See, in the deadly triangle for the maternal mortality, the PPH stops the most, first, and next comes the PIH. PPH, any patient can develop the PPH. So every patient who delivers, the obstetrician should anticipate a postpartum hemorrhage and take measures. Now the active management of third stage of labor is very much helpful to prevent the blood loss following labor. So, and by having repeated CMEs and the drills, I think we will be able to educate the medical officers in the periphery and reduce the postpartum hemorrhage and save the mothers as well as save the uterus. Now a lot of new things has come like SR cannula. So every PHC should have this cannula and it has to be used promptly. For using that, they should undergo the drills, obstetric drills and the workshop. And coming to PIH is a disease due to pregnancy, the preeclampsia, where the exact etiology of it is not known. And again, each individual has their own threshold for the blood pressure. So we have to be very careful. Though we may not be able to prevent the preeclampsia, we should prevent eclampsia, which is a dreadful complication of preeclampsia and contributes to the maternal mortality. So the use of magnesium sulfate in primary health center should be promptly done for the indicated cases. And I congratulate Dr. Radha Madhavi for conducting this repeated CME programs on pregnancy-induced hypertension and postpartum hemorrhage to enable our caregivers to better offer a better service to our patients and reduce the maternal mortality. I wish the CME all the success and thank you for the opportunity given. Thank you.
Radha ma'am, kindly introduce Alamel ma'am, please.
MBBS DGO, she is from Tanjavur Medical College, undergraduate and post-graduation from Kilpak Medical College, consultant Jaya Hospital, Thiruvannamalai, and Chief Medical Officer, Government Hospital, Tirukkovil. Dr. Alamelu, you take over this proceedings.
Thank you, ma'am, for your kind introduction.
You are the chairperson.
Alamel ma'am, please speak. Next CV, please. Priyanka Roy CV, please. Alamel ma'am, you are muted, please. You are muted.
Shall I introduce ma Priyanka Roy?
Radha madam, நீங்க மியூட்ல இருக்கீங்க மேடம். மியூட்ல எடுங்க மேடம். மியூட்ல இருக்கீங்க.
Unmute Radha. Radha, unmute.
And a very happy good evening to all. And I feel delighted to introduce our speaker, Dr. Priyanka Rai. Yeah. Assistant Professor.
Radha, you unmute. Yeah.
Audible, ma'am?
Yes, ma, yes. Now it is audible.
Yeah. Organizing Secretary of East Zone, UBA FOXY 2020 and International WTOG Conference 2021. And he's published more than 70 articles and in various international and national journals, and he has authored more than 25 chapters. Well, and the awards is the gold medal for topping in MS University exam in 2016, FOXY Korean Award, FOXY Future Award 2017, and a lot more to go. And I'd like to introduce her, sir. So please welcome to the dais. And handing over to Dr. Priyanka Rai.
Stop sharing, please.
Good evening, everyone. Is it audible?
Yes, sir. Yeah, yes, yes.
Adile volume கம்மி பண்ணிருக்கீங்களா? அதுல கேக்குது. அதுல I think so we reduce. It's okay. Okay. First time, the hybrid session பண்றனால கொஞ்சம் கன்ஃபியூஷனா இருக்கு. I'm just trying to open my PPT. It says host disabled participant screen sharing. Can you please enable it for Dr. Radha Madhavi?
1 minute, sir.
Sure.
Yes, sir.
Is my screen visible?
Yes, sir.
Sure.
Sir, kindly go to screen slideshow mode.
Okay, ma'am. Vandacha?
Sir, this is Chitra here. Sir, can you please stop share
Yeah.
and share, like while sharing, please click on the screen and share. Don't click on the PPT, sir.
Okay. Ipo therida?
Yes, sir. Perfect, sir.
Sure.
Yes, sir.
Okay. So good evening, everyone. Ellarku vanakkam. And I'm so happy to be back to Tamil Nadu once again for this talk. I was at Chennai today in the morning for another session, and it's really a matter of privilege to be here with all of you at the Tiruvannamalai OBGYN Society and also in the front of TNFOG in delivering this talk on an obstetrician's nightmare, preparing oneself legally and clinically to manage PPH. It's almost 8:45 in the evening, and I see physically almost more than 10 people who are present over here. And I thank Radha Madhavi ma'am and the team Tiruvannamalai OBGYN Society for having me here, for giving me this opportunity to be here with all of you.
Dr. Priyango,
Ma'am,
sound is less, so you have to increase your voice.
ma'am, mic le
Yes.
Kekliya Sariya?
Yeah. Have
Is
the
it
mic
okay now?
close to your mouth.
Is it okay now, ma'am?
Okay, better.
Sure. Maximum yes. Okay, so going ahead with this talk on an obstetrician's nightmare, preparing oneself legally and clinically to manage PPH, and I'm sure after this Sampak ma'am will take a brilliant panel on PIH. So to start off with the talk, I would like to start with a famous quote by Professor Muhammad Fathallah, who was a FIGO president from 1994 to 97, and he said, "Women have a human right to go safely through the risky journey of pregnancy and childbirth, a right that should be respected, protected, and implemented. And who better than us obstetricians to protect this right of women and to give them a respectful care, to get them out of this pregnancy without any much of complications for herself and as well for her baby." So postpartum hemorrhage, we all know it, is a leading cause of maternal death worldwide, almost 25%. Most PPH associated deaths will be avoided by prophylactic uteronic agents in the third stage of labor as well as appropriate treatment, and mostly 75% cases occur within 40 minutes of birth. And that is when we'll have to be the most careful, and we have to take care so that there's no much of complications that can happen to this lady. Now remember this last three words that I put over here: predict, prepare, and handle. For us, prediction is not something that we can do, because prediction is not possible, because every pregnant woman can go into PPH. So there's no prediction when we talk of PPH. We definitely have high risk of PPH, but there's no prediction that we can talk of. But we can definitely prepare ourselves and we can handle the situation better. And that is what we will look in this presentation, to see how we will prepare the situation better and how we will handle the situation well. So as I've mentioned about the prediction bit, 2/3 of women who have PPH have no risk factors, and we all know it. In the middle of the night, when a patient lands up in the hospital, suppose it's a second gravida, third gravida, usual scenario is you tell the nurse, "Neenga paakuringa inniki night, naan inniki night varala, naaliki kaalayila vandu paakuren." And that is the patient who will land with PPH. If it's a case of a previous cesarean section, most of us will land in the hospital, and the patient pathira, then we'll decide what we have to do. But those low risk patients which did not have any complications, angeta namalukku problem irukku. So that's why understand that every patient is a high risk bomb for a PPH, and we will have to take it forward for the management from there on. Redefining the concept, that is every pregnancy is at risk, that I mentioned, and current approach to reduction in the maternal mortality is something that we need to look at and we need to take it forward. We will quickly brush through the slides which are not very important for the management because Radha Madhavi ma'am has given me 30 minutes and I'm already seeing she's looking at her watch to see how much time I've already taken. So how can providers prevent a woman from dying of PPH? Of course, simple interventions save 60% of women, and 60% of women's life is a considerable bit when we talk of MMR. We already have a target of reducing the MMR considerably, and I feel very proud to today sit in one of the states of India which has almost reached the MMR goal that has been given by the government of India. Kerala, Tamil Nadu has been doing wonderfully, and I am also very proud to say that I'm a student from Tamil Nadu. I have studied my MBBS from here, and I feel very proud whenever I see that this state is still doing wonderfully well and taking all the good steps that are required to save the life of a woman. So WHO recommendations for AMTSL, that is the active management of third stage of labor. And we all know the important points. We have all been practicing it all our life. But there is one point that I would like to highlight over here. That is in the setting where skilled birth attendants are not available. So that means the DICE. So ASHA workers are also to be instructed or to be told that in case a DICE is delivering a lady, controlled contraction is not something that is recommended because the chance of a uterine inversion is very, very high. The other points we all know of, that is uterotonic or oxytocin that can be administered 10 international units, 1 to 2 minutes within the delivery of the baby. Plus we talk about the controlled contraction and also the uterine massage that can be given after the delivery. So this illustration will show you the images of the various AMTSL manifestation that we can talk of. The first one, administration of oxytocin. Second one, delivery of the placenta by controlled contraction. The third one, inspection for any vaginal tear as well as some bit of uterine massage. Fourth one is something that has come in now and is a favorite for most of us because encouraging breastfeeding is something that has gone a long way in preventing PPH as well. It initiates the oxidative pathway, and with the pathway of oxidative pathway that is initiated with breastfeeding, it decreases the chances of PPH by increasing the oxytocin secretion and hardening the uterus further. So PPH prevention first, that is identify and correct the risk factors, AMTSL and uterotonic during the third stage of labor in all births. Risk factor, prevent high risk factors and low risk factors. I will not talk of this because I've already told you every pregnancy is a risk factor for PPH, but there could be some extra additional risk factors that you can talk of is probably multigravida, placental abruption, anemia, low platelet, and also in case where there could be uterine overdistension like multiple pregnancy, hydramnios, etc. So active management of the third stage of labor. Late cord clamping. This is an initiative I hope all of you over here have already started. Late cord clamping. Clamp the cord in around 1 to 3 minutes. That is the added advantage of that extra bit of blood that flows from the mother to the baby. That decreases the chances of anemia in the baby, and also it has that additional factor of preventing much other complications in the baby also further after birth. The second advantage with this is also that it decreases the chances of retained placenta and also decreases the chances of PPH. This was a simple study that I had done during my postgraduate days when I was in JSS in Mysore. It was a study in which the placenta clamping versus unclamping and to look at the duration of third stage of labor. So what we used to do, we used to clamp the placenta on the cord on both sides after the delivery of the baby. The umbilical cord was cut and the baby was handed over to the pediatrician. After that, in one group of patients, the clamp was released and the blood was allowed to flow into a kidney basin. So the patients in which this blood was allowed to flow, they had considerable decrease PPH and also decrease in the third stage of labor than the patients in which the cord was continued to be clamped. This is the same concept where we allow this blood instead of flowing into the kidney basin to flow into the baby. Thus all the blood from the placental bed flows into the baby. That blood, considerable loss of blood does not happen for the mother as well, and that advantage for the baby as well sets in, and that gives a lot of benefit to the baby. Second is control contraction, skin to skin contact for 2+ hours as much as possible. Initiate breastfeeding at birth itself directly In a normal delivery, put the baby on the mother's abdomen directly, and in case of a cesarean section, after the clamp is cut, the cord is clamped and cut, you can hand over the baby, you can put the baby to the mother's breast first and then hand over to the pediatrician for further resuscitative measures. This is also to remember that in case if there are no complications, then we go ahead in this way. If there are any complications for the baby, like any meconium aspiration, etc., then we will hand over the baby to the pediatrician immediately. Now, uterine tonus assessment, massage first 2 hours, and also the uterotonics that we need to administer in these patients. So what are the uterotonics that we can administer in these patients? It could be oxytocin, it could be misoprostol, argometrin, oxytocin, argometrin fixed dose combination, and carbitocin, which I would not say is a new kid in the block. This kid has been there in the block for quite some time. It's just the confidence that we need to get in administration. கொஞ்சம் வெளியே போய் பண்றீங்களா என்ன பண்றீங்க நீங்க சவுண்ட் வரது இங்க டிஃபிகல்ட் ஆகுது. Yeah. So carbitocin is not a new kid in the block now. It depends on your experience, depends on how you want to administer this molecule, and probably based on that you can take it forward. So oxytocin, of course, not much to talk of, has been a gold standard that we have been using it for so many years now. It is given in 10 international units IM or IV. Misoprostol, aptly administered even when there is no doctor available. It can be administered at 400 to 600 micrograms per orally, per rectally, per vaginally, whatever route that suits you best. Argometrin, I don't think many of you use it now because it's going a little off the track. And carbitocin is another molecule that I would like to talk of, recommended in context where the cost is comparable to other effective uterotonics. It's heat stable, that's the most important bit, and needs skilled health personnel to administer. So when we talk of uterotonics, when we started talk of carbitocin, when the first time carbitocin talk we had in Siliguri, we did talk of the first and most important thing, that was the cost factor. So we started off with one of the molecules which costed 490 rupees at that point of time, and now there are other molecules which have come to a price of somewhere around 420 to 470 rupees as well. So when we added the total cost of administering oxytocin, also remembering the fact that Williams tells us oxytocin is to be administered in non-dextrose containing fluid only. So that means we are supposed to give it in ringer lactate solution. So when you give oxytocin injection in ringer lactate solution of around 6 to 8 ampules of oxytocin that is required in 4 bottles of ringer lactate, the total cost that we calculated was 650 rupees. And when we talk of carbitocin, it is a single dose, single shot molecule that is administered directly, intramuscular or IV, that can be given, that costs you 420 rupees. So it's the confidence factor that is most important, and it's not always the cost factor that we need to think of, that we think of when we talk of carbitocin. The added advantage with carbitocin is the heat stability. Because in oxytocin, until and unless oxytocin is stored in a fridge, is kept properly in a fridge and stored in cold temperature, it is as good as distilled water. Carbitocin, that is not a problem, because we know in India you may get your oxytocin and store it in your fridge, but you do not know how that got carried. The supply chain is not something that we can vouch for, or we do not know how well it has been. But with carbitocin, even if it comes in no cold chain, it does not matter, because the molecule is good, it's heat stable, and there is no much of a problem that we administer. One of the problems that we faced when we started with carbitocin in Siliguri was the anesthetist. Because they were the ones whom we tell to administer. They are not convinced should we give carbitocin. They are not convinced with the fact if we give carbitocin and if the bleeding still happens, what will we do? But till now, we have administered in so many patients, and it's been only one shot of carbitocin that has acted brilliantly without any much of a problem for our patients, and there was no much of a PPH. Initially, the first 4-5 patients when I administered carbitocin, I got really scared, because the uterus got so hardly contracted that I thought, I mean, that is not something normally that we see. But then with this, now that I realized that is the normal, there's no bit of bleeding at all. The placenta separates on its own and comes out almost till the cesarean section incision side, and there is no much of a problem that happens. Now, also, I will also mention a couple of side effects that we noted when we used carbitocin in Siliguri. There are a couple of senior doctors in a vaginal birth when they administered carbitocin. Before the placenta was separated, the uterus contracted so hard that the os closed off. So in those cases, these 2 cases, what we could do is, with the instrumentation, in one of the cases, they put in the instrument in the uterine cavity and deliver the placenta. The second doctor did not do that. He shifted the patient to the operation theater, give the patient general anesthesia, the os dilated on its own, and the placenta could be delivered. So these are the two ways I think that will help us in the administration of carbetocin with good effects. Now, looking at the concerns of available uterotonics, they require special storage, questionable efficacy after the drug degradation, and associated side effects that we need to look at. Carbetocin will talk a little bit more because the other molecules we have used for all these years, we know about them, and this one we'll talk a little bit. It's a synthetic oxytocic analog with an increased half-life in plasma and high lipophilicity, increases the duration of action to 4 to 7 times more than that of oxytocin. It has got a similar efficacy and safety profile to oxytocin, but carbetocin reduces the need of uterotonic interventions and uterine massage, reduces the need of additional uterotonics, has more women experiencing blood loss less than 500 ml. This was a study that was published in our Cochrane collaboration. This was by Su LL et al. Carbetocin for preventing postpartum hemorrhage review, and they included 11 studies involving 2,635 women. And they concluded carbetocin was associated with a reduced need for uterine massage following both cesarean and vaginal delivery. And when you talk of with argumentary in the comparison, it was good enough and it could be given in case of hypertension as well. So now the next thing that we need to discuss and we need to think of are carbetocin. Is it safe to give in all sorts of conditions? So carbetocin initially when we started off was considered to be as good as we used to give it in oxytocic patients. Even in patients with hypertension, carbetocin is cleared off. There are 3 recent studies which have been published which talks of carbetocin being completely safe and can be given in cases of preeclampsia as well. Only thing that is not clear yet is complex congenital heart disease, where we are not sure the effect of carbetocin yet, and carbetocin is still not considered to be a safe molecule in cases of complex congenital heart disease. Whenever we talk of carbetocin, we talk of the Champion trial, which said this data informed care of women in parts of the world where lack of heat stability is a barrier to effective prevention of postpartum hemorrhage. So that goes on to say it is equivalent as good as with oxytocin, probably better than the effect of oxytocin, and is best in which heat stability is an issue and we do not know whether the molecule or the batch of the oxytocin that has come to you is completely heat stable. WHO study shows that this drug could save thousands of women's lives, and that was a news release that was published. So in 2019, they included it in the essential medicine list of in case of PPH, and carbetocin was added in the 21st WHO essential medicine list. Now, this was what I just mentioned to you about. This was another study that was published in prospective cohort study evaluating the cost, and this was a study that was done in Peru, which talked about carbetocin ultimately goes on to prevent the amount of cost that you're talking of, and there's no much of additional burden cost-wise that we can think of, which we normally think. So if you sit yourself and calculate the cost factor, you will realize that the cost is not more than when we use oxytocin for our patients. Now, frankly speaking, the textbook or the molecule catalog says carbetocin alone is good enough when we are giving it for administered in case of PPH. When I do cesarean sections in my own hospital, administer only carbetocin single ampule, and that because I have my people who monitor the patients in the hospital, I will get information from at any point of time if there is any excessive bleeding. But when I go to a periphery hospital, I give 1 ampule of carbetocin along with misoprostol, 4 tablets per rectally that I also insert because I want to give that additional factor as well towards uterotonic agent. But in my hospital, using this carbetocin single dose for all this while, I haven't had much of a complication with PPH, I must say, and it has worked brilliantly in all this while without much of any problems. Now, my anesthesia is also quite comfortable with carbetocin, and we have been using this molecule for this last so many years now. So carbetocin, the onset of action is within 2 years. Half-life is 33 minutes when it's given IV and 55 minutes when it's given IM. Duration of action is 60 minutes for IV and 2 hours when it's given IM. Dosage and the mode of administration is 100 micrograms administered IV slowly over 1 minute or IM. Now understand this. I have seen when I give this talk across, I have heard a lot of people giving their experiences of using carbetocin. Some of them say they use carbetocin by putting it in 100 ml of normal saline. Some say they put it in 500 ml of normal saline. Please do not do anything of that sort, because we have to follow the catalog of the drug. We have to do how it is administered. So the ideal route of administration, if you're giving it IM, if you're giving it IV, give it a single shot over a period of 1 to 2 minutes. And if you're giving IM, you can give IM shots same over 1 to 2 minutes. And that is it. And that will work wonderfully without much of your complications. I think you should start using it. And once you start using it, you will understand the effect of it. Of course, for any molecule, until and unless we start it, we will not know the complications, we will not know how to use it. Once you start using it, you will know the additional benefit of it. And since this molecule is now approved, it can definitely be used, because you will not have any medical legal implications as well. So it does work wonderfully. After maybe you can use some and you can see how it goes on. So this is the updated WHO recommendations for PPH. 3 important questions that WHO asks. Are skilled health personnel who can administer injectable uterotonics available? If it's a no, then go to misoprostol. If it is a yes, is oxytocin available? If it's a yes, the most important question is oxytocin of sufficient quality available. If that is a yes, then only administer oxytocin. If it is a no to any of the others, the first molecule that is usually talked of, you can see the box on the left side on the top, heat stable carbetocin is the one that they talk of as a first molecule, and that can be administered in patients to manage or to prevent postpartum hemorrhage. Now, coming to the basics, back to PPH. Now, this prevention we talked of. Now we'll talk of PPH, and we'll talk a little bit about the management of PPH. Thankfully, I don't see Radha Madhavi ma'am looking at her watch anymore. So I think I have some time that I can go ahead and talk a little more. So blood loss in a normal labor, 500 ml is what we talk of. Cesarean section, 1000 ml. Cesarean section for hysterectomy plus hysterectomy, 1500 ml. And if it's an emergency obstetric hysterectomy, 3500 ml we talk of. As per the ACOG definition, 10% fall in hematocrit is what is called as PPH. Bleeding producing hemodynamic instability is what we understand by it. So PPH is an excessive blood loss with its primary PPH within 24 hours after birth. Blood loss of any amount that causes hemodynamic instability. Massive hemorrhage means more than 2000 ml, usually accompanied by hemoglobin drop of more than 4 gram%. Coagulopathy, need for massive transfusion. Just to clarify one more thing over here, for maybe the postgraduates who are present or the juniors who are present on the Zoom platform, testing of hemoglobin within 24 hours doesn't make sense. Please do not test hemoglobin within 24 hours because you will not get a true picture. You can probably do a PCV to look at what the level is, but hemoglobin is to be done only after 24 hours, and that will give you a picture. Ideally, it says 48 hours, but at least after 24 hours to get a true picture of what is happening. So immediately after the delivery, please do not send a complete blood count to look at the hemoglobin and the total leukocyte count, because it does not make sense. You send it after 24 hours, which will give you a true picture, and based on that, you can also cover the patient with antibiotics if you feel the septic coverage in a hospital is not good enough. So how do you estimate blood loss? It could be visual estimate, weighing of surgical dressing, collecting devices, and the various clinical parameters. So visual estimate of blood loss, an important slide I must say. The first, these are all mops which are around 10 centimeter in diameter. Subjective may underestimate large losses up to 2 to 3 times. The first one you see, that is 25 ml of blood loss, that is 50% of soakage of the mop. The second one, 75% soakage is almost 50 ml of blood loss. Third one, 100% of soakage, it's around 75 ml of blood loss. And if the mop is dripping, sometimes in smaller hospitals, we tend to press the mop and drain the blood to again use the mop again. So that dripping of blood that you do is 100 ml of blood loss that has already happened. So other visual estimate methods, puddle of 50 centimeter in diameter is approximately 500 ml of blood loss. Puddle of 75 centimeter in diameter is 1000 ml of blood loss. Puddle of 100 centimeter is 1500 ml. Bed with puddle of blood on the sheet is probably less than 1000 ml, and vaginal bleeding with blood flowing to the floor. I must say, if you are having a situation like that, please do not use that hospital or do not do your cases in the hospital, because if it has gone to a scenario where the patient has not been monitored, she has bled so much that the sheet got soaked and came to the floor, that's almost 2000 ml of blood loss, and that is a very sorry scenario, and it will be very difficult for us to bring that patient back to life by resuscitating a hemodynamic status as well. So now looking at this collecting device, which I very proudly again say has been developed in Karnataka in the Belgaum hospital, which is called the brass feed tray. This is a collecting device in which the device after the delivery of the placenta is tied to the patient's abdomen and the blood flows into the bag, and we know the exact amount of blood loss that has happened because in this conical bag you will have the markings and you can measure the blood from that. So the clinical parameters of blood loss, clinical signs. First, tachycardia, hypotension, and reduced urine output. Let us not talk of reduced urine output because we do not want that patient to go to that status. Tachycardia, definitely you should pick up. Put a patient in case if you do not have a good staff to monitor in your hospital, have pulse oximeters or you have cardiac monitors in your hospital where you will get the tachycardia that will be seen on the screen and you can pick it up from there. Hypotension is a second thing, and the third thing is reduced urine output. And when the patient has gone to reduced urine output, there are high chances that the other organs like kidney, etc., can also be already damaged or already in the process of insult. Shock index, very important. How do you calculate a shock index? First of all, it's the heart rate divided by the systolic blood pressure. If it is more than equal to 0.9, you have to call for help. So if the heart rate suppose is 120, the systolic blood pressure for the patient suppose is 90, the blood pressure is 90 by 60. So let's consider the systolic blood pressure is 90. So that means the index is 1.5. That goes on to say that the patient is in shock. You will have to definitely call for help and you will have to take management modalities as quickly as possible. A very common graph when we talk of in any talk of PPH, the golden hour in PPH. That is to show you the amount of survival chances in case you land up in a case of PPH. If you diagnose it within the first 10 minutes, the chances of survival is as high as 80 to 90%. But again, if you see the end of the graph, the last end of it, if you see that if you have diagnosed at 1.5 hours, that is 90 minutes, the chance of survival is only 1%. So that goes on to say that the golden hour of PPH, I would not even say golden hour of PPH. Now I would say golden minute of PPH probably is something that we can come to. The best diagnosed at the earliest, treated, managed, the patient goes perfectly fine without any much of complication. Any bit of probably carelessness from our side, not monitoring the patient well, is sometimes that we can land up in complications. So PPH management, first of all, communication, resuscitation, monitoring, investigation, and arrest of bleeding are things that we need to look at. So communication, before that, prevention of PPH is easy, treatment is difficult. So let us always try to prevent PPH. Communication, the most important is consent taking. It's very important for us to listen, discuss, share with the patient all the information, respect the decision, and make it medically safe for yourself. Previously, we used to say, whenever we have an obstetric case, we have to look for the safety of the mother, the safety of the baby. But now I like to add up a third arm in which I say safety of the mother, safety of the baby, and safety of yourself. That is us obstetricians. Any bit of complication anywhere will lead to unsafe situation for us, for our hospital workers, and as well as the hospital where you're working in. So make it medically totally safe for yourself. Approaching a consent, adequate privacy is to be given. In case if there's a PPH, you need to do something, you need to get blood, you need to get a blood transfusion consent as well. Remember that, and you need to take this consent at least by a junior doctor. Please do not send. I have seen instances where there are nurses sent, there are security guards who are told, go take a consent and come. Manager of the hospital is taking a consent. Please do not do anything of that sort. I understand in smaller nursing homes when we are doing a cesarean section, maybe you are the only doctor available there and you do not have anyone else other than the nurses who could assist. Please request your anesthetist, have them at your, as a friend of yours, give them chocolates sometimes so that they do this additional favors for you, where they can go outside, probably take a consent for you in case if it is required, but then keep them in good books of yourself. If your husband is your anesthetist and if you have fought with him, do not take him for that day for your case. Take someone else as an anesthetist who is your friend, and then maybe when you are in good terms with him, bring him back as your anesthetist for that case. So consent is important for the patient and the guardian to sign. Doctor is a must, and witness again from the side of the doctor as well as the side of the patient. It's also a must. Written consent is mandatory. The burden of proof is with the doctor, so written consent is compulsory. I add this line because there are other couple of methods of consent that I'll also talk of. Never forget, you cannot do anything more than what you have taken a consent for. So you suppose it's a case of a placenta accreta syndrome and you have taken only a consent for cesarean section. Make sure you take a consent of hysterectomy also if you feel it is required, because in these patients, whenever you have to do something extra, take an additional consent. If you do not do it, come outside and tell that I have not done it and take a negative consent again. But do not do a procedure for which you have not taken a consent. Remember, patient's consent nowadays is a must. You can take the relative's consent only when it's a life-saving procedure or life-saving situation for the patient. So if it's a case of a placenta accreta syndrome and you end up doing a hysterectomy, if the patient, even after getting saved, goes and says in the court that why was hysterectomy done for me, you will not be able to save yourself if you have not taken a consent. Because nowadays, placenta accreta syndrome, gone are those days where we used to diagnose it intraoperatively. Now it is diagnosed pre-operatively by a good ultrasound, or a MRI can also be done to diagnose a placenta accreta syndrome. Take a proper consent and then only go in for a procedure if and when it is required. Now, few of my personal views, I would say, video consent and the feedback forms. Two very important things. Video consent is very, very important because a common scenario when there is some problem that the patient lands up in, they will come and they'll tell you, நான் இந்த consent கொடுக்கல, எனக்கு blank formல sign வாங்கிட்டு போயிட்டாங்க, அதுக்கப்புறம் என்ன எழுதுனாங்க எனக்கு தெரியல. That's a usual picture that we see. But then when you have a video consent, you have taken the consent in the presence of a video recording where audio recording is also present, they will not be able to deny that fact and they will have to accept the fact that they have signed that consent after everything was written in that consent form. Second important thing is feedback forms. Usual problems, now first level, when I was thinking of this, I was also thinking, how will feedback forms help us in our day-to-day practice? But it's very, very important because usual problem, mainly problem will be there when you charge a patient 50,000-60,000 rupees. அப்பதான் சொல்லுவாங்க எனக்கு சர்வீஸ் சரியா கிடைக்கல, எனக்கு இதே பண்ணல, எனக்கு அதே பண்ணல, நிறைய things they'll say and they'll get the political boons involved and there'll be a lot of problem for us. So you remember when you have a feedback form that you have given to the patients, every day they have given you a feedback saying that I've got good service from the hospital. On the day when they get discharged, they cannot tell you that I have not got good service. You have those forms with you, which you can produce in front of them, also in the presence of court, in case if it comes to a case, which will say that they have given us good feedback for the first 4 days. Only on the day of discharge, they realize that things were not all right. And also a secret, of course, we all know it. When a patient is undergoing a treatment with us, they will not give you a negative feedback. So first 4 days, whenever they admitted, they'll definitely give you a positive feedback. For whatever they say, when you have those feedback forms, doesn't matter much to us. Because we will have to definitely try and find out ways to save ourselves because it's quite a bad scenario that we are going through right now. So the main problem, I don't know, Hindi le vande solvanga, kuch nahi hota hai yaar, means ena onnume problem avade panilla. Please do not do this. This onnume avade problem was the main problem that happened in the case of Dr. Archana Sharma, who unfortunately had to commit the suicide because she did that case in a very small hospital in a severely anemic patient with a lot of complications, which is not something that is warranted. Any case can land you up in trouble, so do not take this casual approach for any of your patients. This is a line that I've taken from one of the talks of Dr. MC Patel. First line, which I do not follow: eat less and walk more. I eat a lot and I do not walk much. Do necessary and talk more. I'm very sure most of you do it for your patients and do yourself. Third line, work enough and write more. I'm very sure all of you work a lot. That's why we are having this seminar after 8:30 because I'm sure you have worked a lot for the whole day. Write more is the most important word, and we do not write more. We do not document things, and that is where we land up in trouble. Whatever you do in the court of law, if you have not done something for your patient and you have documented, it is considered to be done. If you have done something for your patient and not documented, it is considered not to be done. So everything you will have to document, and also understand in that hurry-burry, when you land up in a trouble, if you try and document something, you will miss out on things. You will probably write, suppose you have written the whole page in a black pen, in that hurry-burry, you got a blue pen and you write it in between. Remember that there will be a page that will not be considered in the court as a good aspect for yourself. It has to be written in order, in a proper way. And remember, when you land up in trouble, you will not find time to write things in a paper. You will have to write it in a proper way from beginning, so that if you land in trouble, even if that paper goes, and once that paper is submitted in Xerox or in copy to the police or to anywhere, do not write anything in between. Do not add anything. So if there is a consent that you have taken, you feel you might have to add something later on, leave some space here and there in between so that you can add things there with the same pen, remember, and with the same person's handwriting. No change of handwriting or no change in the color of pen, or rather no change in the pen, I would say, will be a good way of taking a proper consent. This is a WHO surgical checklist, a checklist that goes a long way in preventing complications. It has got everything mentioned. In today's situation, even if there's a mop left in the abdominal cavity, we are held responsible. If there's a spinal headache and the patient goes to the court, we are held responsible. Why should we be responsible for everything? This is a WHO checklist which is signed by the surgeon, the anesthetist, the pediatrician, and the head nurse, which will give equal responsibility to all of them. I understand at the end of the day, the patient is admitted under us and we may be held responsible for everything, but they also cannot wash off their total responsibilities by just doing the case, taking their money and going on. That is not something that is possible. We have to have this checklist available on the website and can be downloaded. Something that worries me always is the section 302, which says murder, intentional, life and fine, and non-bailable. I've done a lot of webinars with Dr. MC Patel sir. These webinars are every Tuesday at 6:30 p.m. Webinar Murcha in the evening. I think I'll stop obstetric practice every Tuesday. That used to be my schedule. Wednesday and Thursday, I tried to be a little carefully doing my obstetric practice. And when it came to Sunday, Monday, again a busy day, I forgot everything and came back to my usual self. So this cycle went on for me for 1.5 years till I finally realized that for me, it will not work thinking in this way. I will do my practice. There are a lot of medical legal people around who are there to help us. But remember, the biggest help is yourself. If you have everything documented properly, that is the best medical legal help you can do to yourself, that no one else can help you wherever you hire a medical legal consultant. Remember, the biggest lie I tell myself is, I don't need to write it down, I will remember it. For this, you need to have checklists or you need to have 2 brains, which unfortunately none of us have. So we need to improve the safety in the hospital. We need to look at solutions like protocols, standard case notes, etc. And you need to have a CCTV camera in your hospital with recording and a line which says this hospital is under surveillance of CCTV with audio recording. Just you will see by putting this line, there will be a lot of lesser problems in the hospital because they know there are a lot of everything is getting recorded and they will not cause much of a problem in your hospital. Indemnity coverage is something that I'll urge all of you to do. It's a coverage by cover you from Foxy, which basically at a very lesser cost, at a cost of only 7,000 rupees, you can get a coverage of almost 1 crore for indemnity. And the added benefit is in other indemnity coverages, usually it's only 1 case that can be covered in a year, but in this cover you coverage 2 to 3 cases in case you will end up in trouble can be attached in the same coverage. Now, take home message. When I sit in the audience side, this is my favorite slide because I know the presentation is coming to an end. But unfortunately, it is not coming to an end. This is just summing up the medical legal aspects. I'm sure Sampak madam is getting a little angry with me because she's going to take the panel after this. But I'll take another 5 minutes and then I'll wrap up my presentation. So the take home message is, be attentive at your duty. Listen carefully what patient says. Follow all your protocols. Document properly. Second line, rombo important line. Keep friends and help friends otherwise too. Do not be a hindrance for others. PPH is not something that we should say. We all know it. Wherever the patient would have landed up, maybe would have landed up with PPH. We may be thankful that the patient did not come to us and did not land up with this complication with us, but then do not bad mouth about someone else, because this is unfortunate complication that has happened. And get an indemnity coverage of a minimum 1 crore done in case if there are any problems. So the final word, please talk, counsel, please document is what I'll say when you talk of the medical legal aspect. So now the management bit, we'll quickly finish it off. Uterine massage, compression, heating, there's a thermal blankets, oxygen by mask, 2 wide bore IV cannulas to be put in, and an indwelling urinary catheter. For the juniors who are present in this webinar, urinary, always remember, if you're having a patient PPH, one of the commonest causes is full bladder. As soon as you catheterize the patient, you will see the blood, the PPH has considerably come down because the uterus contracts considerably. Lab investigations, usually all of the investigations that can be done, plus the important thing is that ABG that can also be done. And if you have the facility, you can do a thromboelastogram as well. Because a thromboelastogram, I know it's in smaller places, we do not have the facility of thromboelastogram. I do not have it in Siliguri as well. It is basically an investigation. It's okay. It's basically an investigation in which we will know how much of blood is to be given to a patient. So it will tell us whether how much of FFP is to be given, how much of PRBC is to be given, and how much of platelet-rich concentrate is to be given to a patient. I'm sorry for this. So in case if we do not have the thromboelastogram investigation available for us, we can go ahead with something called a massive blood transfusion protocol. So massive blood transfusion protocol means that we will have to give blood at a ratio of 1:1, which I will talk about subsequently in my slides. So the most common 4 T's in etiology, a thing that we have been hearing from our MBBS days: tone, trauma, tissue, and thrombin. So tone, important line, keep calm and do damage control. In case if there's something that has gone wrong, we'll have to do damage control, and that will help us in preventing PPH. So medications, usually uterotonics plus tranexamic acid, oxytocin, argometrin, misoprostol, as well as carbetocin that can be used. Now tranexamic acid, when I talk of tranexamic acid, I have used this molecule, and this is a paper that I had published in the Jogi journal. Role of tranexamic acid in reducing blood loss in vaginal delivery. After administration of tranexamic acid, there has been considerable reduction in the amount of blood loss, and that has now been proven, and also has been come in the WHO recommendation for prevention of postpartum hemorrhage. So tranexamic acid in a vaginal birth, you cannot usually estimate when she is delivering. So when she is in the pushing phase of vaginal birth, that is when you can administer it. And if you are going for a cesarean section, if it's an elective cesarean section, I usually administer it half an hour prior to taking her up for cesarean section. So intrauterine balloon tamponade, I don't know how many of you use the vacuum balloon because it's expensive. So condom catheter is an Indian innovation and is really helps us in case of PPH. So only one thing I talk of condom catheter tamponade is have it ready with you. Do not try to make one when you land up in PPH, because you will not be able to make it in that sort of a habit. How it works, it has the condom catheter is dry on top of the Foley's catheter. You have the tip inside the uterine cavity. The balloon is inflated so that the water does not come out, and you can inflate the condom catheter to minimum of 300 to 500 ml. That how it works. It gets the uterine wall stuck to the condom catheter, and the amount of bleeding that comes out subsequently decreases. So with condom catheter, the added benefit is that, okay, one more thing about condom catheter is when you're removing the fluid from the condom catheter, do not remove it at one go, because the uterus will again get decompressed and again the bleeding will start. So it's always a rule to reduce it by 50%. Suppose you have 500 ml inside, you reduce it to 250 ml, you take out at one go. The uterus will come on stuck to the condom catheter, it will start contracting again. Then reduce 50% again after 2 hours, and slowly reduce the whole thing and take out the condom catheter. You will see the chances of bleeding are at its minimum. For transfer of a patient, you can use this non-pneumatic anti-shock garment. I'm sure all of you in Tamil Nadu know this and you're using it quite well. And that is why the chances of, that is why the MMR plus the PPH problems in Tamil Nadu is quite at its low. When medical methods fail, proceed to surgery before patient deteriorate further. Do not take too much of a time to think what will happen, what should we do. In addition, one more slide, it's missed out in this, I had added it in my modifications which I had made, was about the SR cannula. There is a cannula that has been made, which is called the SR cannula. The SR cannula is basically something like a cannula which we use for a suction evacuation. It's a metal cannula with a lot of perforations on its body. So once the cannula is inserted in the uterine cavity and it is connected to a suction machine, the uterine wall, once the suction is when the suction machine is started and the negative pressure is created, the uterine wall sticks on to the SR cannula. That helps in basically preventing any further excessive PPH. In case of this excessive blood flow, that also flows out through the perforations into the suction cannula, and we also know how much of blood loss is happening in the uterine cavity. In case if you have opened up a patient for a cesarean section or for laparotomy, you can also use the aortic clamp that has been formulated now by Dr. PPH PIH. I have not yet developed the heart to clamp the aorta, but then if any of you have that, you can use it, the aortic clamp. That has also been said to be a wonderful interventional measure to prevent PPH. I still use the routine internal iliac ligation, which still helps me quite well in case of I land in a patient with PPH. The other compressive sutures we can talk of are the Wheeling sutures, the Heyman sutures, the Cho sutures, which are also good enough in preventing PPH. So basically, the ultimate thing we need to understand for prevention of PPH is do not leave the cavity in a state where it can bleed when the walls are not approximated to each other. Whatever you do, the walls should be approximate to each other. All these sutures, it helps by approximating the walls. So once the walls are approximated, there's no much of a free space there, so the bleeding is considerably reduced. The same funda when you talk of the condom catheter or whatever interventional device you use, that is basically the same funda, less of free space, less of bleeding that will happen. The uterus contracts on that, and that subsequently reduces the chances of PPH. Uterine artery ligation, and also of course the internal iliac artery ligation. I'll not talk of the arterial embolization because I'm not sure we do not do it here. Now, emergency peripartum hysterectomy is something that we need to talk of, and how the procedure, that there has been a study that has been published in the recent ACOG journal, which says the procedure of emergency post-peripartum hysterectomy. Some of us clamp, cut, suture. Clamp, cut, suture is the procedure how we go ahead when we do an emergency peripartum hysterectomy. Recently, we have been doing it for quite some time, but now with evidence, we can say it's better when we clamp, cut, remove the uterus, and then go on to suture the clamps. That reduces the amount of blood loss by approximately 500 ml. So that is a massive amount of blood loss that we can prevent in case we clamp, cut, remove the uterus, and further go on to suture. Also remember, when you're doing an emergency peripartum hysterectomy, do a subtotal hysterectomy first. Do not go on to do a complete total hysterectomy, because the time taken is more and the chance of complication like injury to the bladder, injury to the ureter, etc. is much more. Trauma has to be identified well. Maybe it could be a vulval trauma, it could be a rectal trauma, it could be a trauma to the lateral wall of the uterus, which has to be identified and sutured well so that there is no much of complication. Placental fragments, of course, take it out. I prefer doing a manual removal, but there could be instrumental removal as well, which I do not prefer. Manual removal is something that can be easily performed, and if you cannot perform it in the labor room, you can take the patient to the OT under GA. It can be done. Now, this is something that maybe in the next 5 years, all of us will face. Like the last 3 months, I've done 6 cases of placenta accreta syndrome, 3 of which I had to do a hysterectomy alone. Couple of patients in which the bladder had to be resected as well. And there was one patient in which it almost came to the peritoneal cavity and got stuck into the peritoneal cavity as well. The peritoneum as well, parietal peritoneum. So in a case of a placenta accreta syndrome, it is something that because of the number of cesarean sections that we have done in the past, we will definitely end up with this complication, and we'll have to take it forward. We'll have to treat the patient accordingly. But remember, the important thing in the placenta accreta when you're managing is it's a teamwork. You cannot do it alone. Cannot do it in a smaller nursing home thinking I'll do it alone. If there's a problem, I'll shift the patient. If you have not identified placenta accreta and taken up a patient in a smaller nursing home or in a periphery hospital, it's best, even after opening, if you feel it's a placenta accreta syndrome, close the abdomen, shift the patient to a periphery tertiary care center, and let them manage it over there. Do not burn your hands in a hospital where you cannot manage placenta accreta syndrome. If you put an incision on the uterus, any complication further on is yours. My sir, even my father, who is a gynecologist, tells me one thing: it takes you 10 years to learn how to operate. After that, more lifelong, you will learn when not to operate. So we need to understand when and where not to operate. Rather, you can have the skills, but you may not be in the right place to operate that patient. So that is also something that is very, very important. So coagulation defects, this is this one line I would like to talk about here about the massive transfusion protocol. 1:1:1 is what is ideally to be given, and that will prevent complications for our patients. Now the take home message, finally, PPH management, most patients have no risk factors for PPH. Active management of first aid, uterotonic, mentioned is oxytocin, but we have other molecules that can be given as well. Early diagnosis and treatment of PPH, the 4 T's, uterotony is the most common. Code red, have something called a code red. There are 2 things in the hospital that one can have. One is a code blue, which I'm sure all of you know. If a patient collapses, you activate the code blue, and subsequently there is a team that comes. Do you know what a code violet is? Okay, code violet is in case if there's a problem in the hospital, the patient relatives are causing problem, you activate the code violet, where the administration, the police officials come to the hospital for your rescue. So remember, activate code red before you get into code violet. Because once you activate code red, you will have an anesthetist, intensivist, you will have a blood transfusion team person there, so that everything can be managed ideally, and it does not go to a stage that the patient relative have to create complications, so that you will land up in code violet. This is a very important thing. I put it specifically after the take-home message slide, because take-home message slide is when people wake up. People who sleep wake up at take-home message because they know the presentation is coming to an end and they know that they have to clap. So I have put the PPH toolkit after that because PPH toolkit is something that is the most important slide in this entire presentation. Because if you have PPH toolkit in your hospital, it's a must. It has to be checked every day by one of your nurses and signed in the register who has checked it. Reason being, when you use PPH toolkit, it will be used maybe once in 3 months to 6 months. But when you have to use it, you will find most of the drugs are expired if you do not check it. Plus, if you have used some of your drug, it has to be replaced on a daily basis, and then only you will find adequate drugs in this PPH toolkit that can be used ideally for you. So have it ready always in your hospital. This is a dead person who's saying, they gave me several shots of methotrexate and oxytocin. It turned out to be only distilled water because it was not stored well. So ensure the potency of your drugs, of your uterotonics, store it in an ideal place. If you're not sure of your storage, then a heat stable carbidocin is something that you can definitely go ahead and use it. This is the summary of what we have already talked of. Now, just to finish off in the last 1 minute, respectful maternity care is something that is very important today. You have to make her feel special, empower women, and inform the woman and take permission for whatever you do. Even if you're doing an examination for a patient, it's very important for us to take permission and be gentle and comfort her whenever you're doing it. You have to pull a curtain. You will see that respect a patient will have for you when you pull a curtain, which you usually do not. That curtain, we do not want us to be examined when we do not have curtains around us. We definitely, our patients do definitely deserve that bit of respect. I have heard a lot of my friends sometimes talk of, we have a lot of schemes like the ESI scheme, Ayushman Bharat scheme, and they talk of, this is the ESI patient, it's okay. But then every patient is a patient. So we will have to give that much of dignity to that patient and allow a choice of companion to her, because that will also help her in going through labor well. All women are equal irrespective of the financial or the social aspects. So thank you so much for giving me this opportunity. Thank you for giving me that extra bit of time. And I'm sure maybe some of you are not liking that extra bit of time I took, but I am thankful to you for sitting through it and listening to it. Thank you so much once again. If there are any questions, or I'll be up for it, but I think we'll go to the panel discussion. Sampath ma'am is already ready.
Wonderful, Priyanka.
I'm sure all of you would have heard the questions. So ma'am's questions are, how long am I using carbidocin? I'm using carbidocin for the last 8 months. The second question you asked was, other complications apart from the two. I did not face any much of a complication other than those two. The other complication that I rather had was convincing my anesthetist to administer carbidocin. So I had to try to convince her every time whenever I had this thing. So that was something that I had to face. But other than that, no much of a complication that I faced. Third question, atonicity after carbidocin. Not much, ma'am. There have been 2 senior consultants in our hospital in which they had faced atonicity after administration of carbidocin because the route of carbidocin administration was wrong. They administered it in a 500 ml normal saline over 15 minutes, which we should not do. We have to administer it as per the protocol, as well how we have to give it. With that, there's no much of a problem. Fourth one, you said, how do you manage it? So as I said, ma'am, carbidocin is a single shot molecule. If you feel that your tonicity is not good enough after a carbidocin administration, you can go for other routes, especially oxytocin. Argometrin is not something that you should go for. Carboprostin, ideally you should not go for, because the method of the route, basically if you talk of the receptors, is similar when you talk of carbidocin as well as prostaglandins. So you can use oxytocin in those cases. Maybe the best tool that has been mentioned in one of the studies, it's a case series that they have published, and they talked of intramyometrial oxytocin that could be given in this case, in case of a cesarean section. So that is the other thing that could be used. And misoprostol is something, of course, that we can use for 800 to 1200 micrograms per rectally orally that can be given. But with this one, once you start using it, you will realize, because we'll have a lot of questions. We have been told in Tamil Nadu especially to end our meal with Tayir Sadam. We do not question why will we not eat Tayir. That's our case with oxytocin. Because we have been taught about oxytocin right from when we have started obstetric practice. So when we have to shift to something else, we do think why to shift. But again, when there's something better, we do definitely need to try to work it out. We need to try and shift to it. And it's been working wonderfully, ma'am. So that question of yours, if that buts that I also initially had when I started, but once I started it, ma'am, for the last 8 months, there have been nothing much to question ifs and buts. So once you start, I guess next time when I come here, you will not ask that question when you have started up with the usage of tablets. Thank you so much. Yes. Thank you so much, ma'am. Thank you. Thank you.
I request Sampath ma'am to take over the panel discussion.
Yes, Radha.
Adike munadi Sampath ma'am or comments, ma'am.
Come on. Priyanka, fantastic presentation. I have posted in the chat box.
Okay. Oh, I didn't see the chat box. Okay, ma'am. Sure.
Yes, fantastic presentation and covered everything. So
Thank
that's
you so much.
your experience in Siliguri. Fantastic. We will call you to Chennai.
Thank you. Looking forward for your panel discussion now, ma'am.
Yes, yes. You can be also one of the panelists. You can tell your experience from Siliguri. First of all, I thank Dr. Radha and the Tiruvannamalai team for the wonderful organization. This is for the Tamil Nadu PNFOG Magalin Nalam CME. Now I will introduce my panelist. Priya, adutha slide pola.
Yeah. Next slide, please.
Yes, Dr. Manonmani, she is the professor and HOD of Coimbatore Medical College Hospital and President Cox, UG, PG from Madras Medical College, and she has many awards and best outgoing student from MMC and Cox Managing Committee member, co-chairperson, District MTP Committee. Dr. Manonmani, welcome.
Thank you,
madam.
madam.
A very good experience.
Good evening. Thank you.
Yes. Dr. Karpagambal Sairam, she is a consultant, obstetrician, gynecologist, and fertility specialist. And her field of interest is fertility, high-risk obstetrics, and endoscopy. She is the recipient of AICC RCOG Traveling Fellowship in Gyne Endoscopy. EC member of OXY, presented many papers, and she is a peer reviewer of our Joki and consultant at Soy Specialty Hospital, Kaveri Hospital, and Nova IVF Fertility. Welcome, Karpagambal. Dr. Sadhana Devi, she is an MD, OG, FNB, MRCOG, consultant in Bilrath Hospital and Medway Hospital, Chennai, and she has been working with Egmore Institute for more than 20 years. Welcome, Dr. Sadhana. Dr. Meena.
Yes, ma'am. Good evening, ma'am.
Dr. Meena Mahalingam, Senior Assistant Professor, OG Department, OG in Institute of Social Obstetrics and Government Kasturbai Gandhi Hospital. And she has special training in urogynecology, microsurgery, and laparoscopic hysterectomy. And she is a master trainer for many government projects, newborn resuscitation program and NHM products. And she has 13 years of experience and participated in as a faculty in national and international conferences and community participation in adolescent health camp, blood bank camp, district instructor in IAP, NRP, FGM, and training of health workers in NRP. She has received a scholarship from IUGA for attending IUGA conference in Italy. Welcome, Dr. Meena.
Thank you, ma'am.
Mostly all of them are well experienced. Meena, mukame theriyala?
Ma'am, now?
Yes, okay. So I will start sharing my presentation and I will welcome you all. Inclusion.
Ma'am, slideshow, ma'am.
Pora. Yes. So without wasting time, we will go with the presentation. So again, thanks to Tiruvannamalai OG Society for the Magalin Nalam CME. And I welcome the panelists, Dr. Sadhana, Meena, Manonmani, and Karpagambal. See, all of us now, you had a wonderful talk about PPH. In the maternal mortality, mainly the two causes is, one is PPH and next is the PIH. Previously, we called it as a pregnancy-induced hypertension. Now it is called as hypertensive disorder in pregnancy. Previously, we used to consider edema legs, proteinuria, and BP elevated. Now the edema legs, since it is a physiological and most of the patient is having, that category is now removed. And hypertensive disorder in pregnancy is BP elevated and proteinuria. Only BP elevated we consider as gestational hypertension. Proteinuria plus means preeclampsia. We have a baseline of 140/98. If it is increased, we consider them as the pregnancy-induced hypertension. As all of us know, this gestational hypertension after 20 weeks, 2 readings with 6 hours apart. Preeclampsia after 20 weeks with proteinuria. And eclampsia, if not identified, finally it will end in eclampsia with the fits. So the preeclampsia and eclampsia can be superimposed with chronic hypertension. Chronic hypertension being hypertensive patient becoming pregnant, that is before 20 weeks. So pregnant patient becoming BP, we consider as hypertensive pregnancy. So as all of us know, the incidence is 5 to 10%. Any patients can have, but these are some high risk cases: primary obesity, previous PAH, hyperplacentosis, and pre-existing vascular and renal and thrombophilia. And mechanism, as all of us know, it is the vasospasm which leads to decreased uterine placental blood flow, ischemia, endothelial dysfunction, which in turn increases all and producing reduced renal pressure and produces the hypertension. So vasospasm is the etiology. Again, with this hypertensive, mild and severe, when it is 140/90, we consider as mild, and it is above 160/110, severe with all danger signs. Now we will go with the discussions. So first, I would like to ask Dr. Meena, the 29-year-old primary, 24 weeks pregnancy, is referred to your KGH with a high BP, and on examination, abdominal examination was 24 weeks, and FH is good, and BP was 160/100. So Meena, how are you going to proceed with this patient?
So first, I would like to take a detailed history from the patient. Now, she is having a high risk of primary, high risk for preeclampsia, as well as her BP is raised. So I would like to check whether her previous notes show any high recordings, as well as the urine albumin as well, as I want to rule out whether she's a case of gestational hypertension or preeclampsia or a chronic hypertension. And I would like to also take a history about her any headache, blurring of vision, epigastric pain, reduced urine output, and then go through the recordings. Then I would like to go through the scan reports as well, if there is any uterine artery Dopplers done, and check the urine albumin as well, and make a diagnosis. Then I would like to start her on drugs. At this juncture, I would like to admit the patient.
Yes.
And do.
That is the point I want to know, whether you want to admit or not.
I would like to admit the patient and evaluate for the complete blood count, liver function test, renal function test, the PIH profile fully, and also check the urine albumin. Based on the parameters, I would like to go about repeating the profile later. And now I would like to start her on labetalol 100 milligram BD.
Yes, Meena. So fantastic. So if the BP is increased, first, always it is better to admit the patient and take a chance to do all the profile, LFT, RFT, coagulation profile, even the retina and ultrasound, everything you can do, and you can be free. If after that also within 2 or 3 days, if the BP is controlled, you can discharge the patient. So for this patient, all is normal, Meena, and you have started with the labetalol. And how are you going to proceed with the patient? Now she is only 24 weeks.
So I would like to carefully monitor her, as you have said, ma'am. If the BP is under control with the medicines, I would like to carefully, after discharge, carefully monitor the blood pressure. If she is under
What
follow,
will you counsel her? How will you counsel her on discharge?
yeah, I would like to tell her about the danger symptoms, like if she has any intractable headache, vomiting, nausea, and visual scotoma, upper abdominal pain, epigastric pain, or decreased urine output, to report immediately. Otherwise, I like to monitor her blood pressure and also check the urine dipstick to see if she is developing a preeclampsia. As now everything is normal, looks like a gestational hypertension. So carefully monitor the BP and give her drugs. And also like to monitor her
Meena, for BP
ultrasound to
monitoring,
check.
will you ask, Meena, for BP monitoring,
Yes.
will you ask the patient to come to your hospital, or will you advise her to check the BP in the nearby hospital if she is from long distance?
Yeah, we would like to refer her to the nearby hospital. So I have a mentoring. If it is, she is already registered, it will be like urban PHC with a careful monitoring with the village health nurse.
Okay. Whatever it is, some near hospital. If it is a private patient, she can have in the near hospital. So the take home message is the BP has to be monitored. BP is the main important thing. And when are you going to deliver the patient, Meena?
So if the blood
BP is
pressure is
under
under
control
control,
with labetalol 1 BD, BP is with 130/80.
usually we go till 37 weeks, ma'am. If all the parameters, the maternal and the fetal growth, everything is normal, we even monitor till 40 weeks.
Yes, this is a gestational hypertension with everything is monitored, means we can wait till the date of EDD. So this patient is having no alarming symptoms. So when will you ask her to get admitted? Suppose today is her EDD, will you ask her to come out today or 1 week earlier, and again you want to monitor all the things?
If everything is normal, we would like to admit her on the date of EDD, ma'am.
EDD. So what is the mode of delivery?
Based on the maternal and the fetal conditions, monitoring the Bishop score. If Bishop score is favorable, we would like to allow for a vaginal delivery. Most of them, they deliver vaginally and easily as well.
Thank you, Meena. So if the gestational hypertension with the antihypertensive, if it is under control and all other parameters are normal, you can wait till 39 weeks or till the date of EDD also, depending on the Bishop score, you can go for the vaginal delivery. BP increased is not an indication for LSCS. Thank you, Meena. So what are all the other antihypertensive for the sake of audience? You can tell what are all the other antihypertensive and the doses which is available here and which is for the PG students. I think PGs are in Tirunelveli.
Yeah, so labetalol would be the first choice, 100 milligram BD dose. Based on the blood pressure, we do increase the dose to 100 milligram twice a day or thrice a day. And the next drug will be nifedipine. And also like to tell them that she may develop a headache, and the nifedipine dose will be 5 to 10 milligram as a starting dose. And gradually we can increase the dose if it is not controlled till 20 milligram. And the next drug will be methyl dopa. And methyl dopa was the first drug when we were postgraduates. It is given as 250 milligram dose twice or thrice a day, depending on the blood pressure. And this is usually discontinued as there is a risk of postpartum depression immediately following delivery. The other drugs, hydralazine and the hydrochlorothiazides, are mainly tried in emergencies where the blood pressure is not controlled with the oral drugs.
What do you think about the labetalol IV?
Yeah, labetalol IV is mainly for hypertensive emergencies. We do give, and usually after giving the dose, we do monitor the blood pressure immediately after giving within 5 to 10 minutes. And if the BP reduces within 15 minutes, we do not repeat the dose. If the BP is not under control, we do increase the dose till 220 milligram as the highest dose.
So double, 20, 40, 60.
Yes.
Okay, Meena. So already you have mentioned about the alarming symptoms. Once the patient with the gestational hypertension is diagnosed, whenever you meet the patient, ask them the history, whether the headache is present, laryngopatient, upper epigastric pain, and reduced urinary output. Reduced urinary output, patient will not tell. You have to ask. And finally, this fetal movement. So this 5 points, talavali irka, kannu mangala therida, upper epigastric pain for HELP syndrome, and reduced urinary output and fetal movement. In the PIH, we are most bothered with the mother rather than the baby. So this 5 questions you have to put such that you can avoid the complications. Thank you, Meena. Next we can go with Dr. Sadhana. You can take up this patient, I think. This is 32 weeks of primary with complaints of headache, not relieved by rest. And she is having the blurring of vision since 24 hours. And patient was on antihypertensive tablet labetalol VD since 4 weeks. How are you going to proceed with this patient? Dr. Sadhana, are you there?
Yes, madam. Yes, ma'am. She is a case of 32 weeks primary. A full assessment should be carried out in a secondary care setting if she is visiting us first time. So this woman has got, she's a primary with 32 weeks already booked somewhere and she has entered our setting. Now she has complained of headache. So we need to, and along with blurring of vision, we need to look into other symptoms also, any epigastric tenderness, any blurring of, already blurring of vision is there. And she's on antihypertensive. A detailed history about labetalol, how
BP
she's
is
taking.
normal. With the antihypertensive, her BP is normal.
A fundal examination.
Yes. It
A fundal
corresponds
exam.
to gestational age.
Yes. Yes. BP is controlled with labetalol, and fundal examination is usually advised for the women, and other blood parameters are blood tests which include full blood count, RFT, LFT, coagulation profile, including platelets is advised for the women. And urine for proteins. Initially, a urine dipstick for proteinuria is advised. If it's more than 1+, we label the women as preeclampsia. And once she is more 1+, we need to quantify the proteinuria depending, and we need to do protein creatinine ratio for this women. So this woman can be labeled as preeclampsia, and if the BP is getting controlled, we can label her as mild preeclampsia with antihypertensives, labetalol. A fetal
now
assessment
she is having a continuous headache and blurring of vision. How are you going to proceed with the patient? BP is under control with the labetalol. But this alarming signs are present.
Alarming signs. A fetal assessment also needs to be done for this women. So fetal assessment, we need to look into the gestational age, whether it's corresponding to it, any features of fetal growth restriction, and ultrasound of the obstetrics should be done along with a Doppler to look into any features of growth restriction. Whether the amniotic fluid is correct, and umbilical artery Dopplers are also advised. And along with it, if the headache and blurring of vision, since she's having persistent headache and blurring of vision, and the BP is getting controlled, we can, if the fundus is normal.
So for her, LFT is normal, RFT is elevated, coagulation profile is normal, proteinuria is plus, but headache and blurring of vision is persistent.
So this woman is labeled as severe preeclampsia, and we can administer magnesium sulfate for this woman. So magnesium sulfate should be 4 grams IV loading dose in 20 minutes, followed by 1 gram per hour as an infusion for 24 hours. And along with it, the BP is not under control with labetalol, we can switch over to other antihypertensives can also be added. But fortunately, this woman is well controlled with labetalol alone. So magnesium sulfate would be sufficient for her. So we need to hasten delivery depending upon the parameters. Since LFT is elevated, delivery can be
normal. Sadhana, LFT is normal. RFT alone elevated.
RFT is alone elevated. So RFT is elevated. We need to look into other parameters, whether there is any pre-existing renal pathology in this woman. So like we need to continue, we need to admit this woman and monitor her sequentially, so that depending upon the instances, like we can deliver her.
Sadhana, for the sake of audience, can you tell the picture regimen? How will you give the magnesium sulfate loading dose?
Here in IOG, we usually administer.
No IOG. Generally, you tell. No IOG.
Generally, we usually we take 4 grams of magnesium sulfate at 20% loading dose. As a we give them as an infusion in 5 to 20 minutes. Then we take about 1 gram per hour as an infusion. We set an infusion pump, and it's delivered in 1 gram per hour for 24 hours. So we just drop 24 ampules into an infusion pump, 50 ml syringe, and we put it in an infusion pump as we set the infusion pump to 1 gram per hour, so that it goes continuously for 24 hours. So it can be 24 hours after the last fit or 24 hours after the delivery of the baby, whichever is early.
So for the sake of audience, magnesium sulfate available is 50%. So as she told, each ampule is 2 ml, each ampule is 1 gram. To give 4 gram, Amina, can you tell?
Yes, ma'am. So actually, Pritchard regimen was followed when we were postgraduates. So that was 4 grams as a loading dose. IV. So we need to prepare the dose. Each ampule contains 1 gram, that is equal to 2 ml. So we take a 20 ml syringe, and taking 4 grams is equivalent to 8 ml plus 12 ml of sterile water or saline, and then given over 5 to 15 minutes. During that time, we do watch the respiratory rate, ankle clonus or the patellar reflex, as well as the urine output. For the first dose, we need not check whether the urine output is there or not. And followed by Pritchard regimen, when we were giving, it was 5 grams in each buttock. The first dose will be 10 grams in each buttock. So it will be around 14 grams. Later, so the IV dose is 20% weight by volume, and the IM dose is 50% weight by volume, because we are not going to dilute the IM dose. Followed every 4 hours. That should be given for 24 hours after delivery or last fit, whichever is later. This was the Pritchard regimen, which was followed when we were postgraduates, as Sadhana ma'am told. Now we are following the Zuspan regimen, which is 4 grams IV loading dose, followed by 1 gram infusion per hour till 24 hours after delivery or last fit, whichever is later. So we do have an infusion pump in which we load the 24 grams, that will be equivalent to 48 ml in a 50 ml syringe, and that is given set at a rate of 1 gram per hour. That will be given for 24 hours. This is the Zuspan
So Sadhana and Meena, it's okay, but in the primary health center and in the periphery, still they follow the same only. 4 gram 20%, as you all told, 8 ml in 20 ml syringe, dissolve with 12 ml of normal saline and give within 5 to 10 minutes. And IM is only 50%. So 5 ampule in our right side and 5 ampule on the left side. And as you told, it is to be monitored in the periphery. I think it is the same thing is followed. Manonmani madam, are you following this or Zuspan?
No, madam. IM dose and the infusion pump, depending upon the patient. Actually, IM also we are using it. IV also for few patients use. It is not like one for all rule. Yeah. And then shall I add one more?
Medical college protocols.
Yes, madam. Shall I add one more thing? That is a 32-weeker. So you have to think of steroids also for fetal lung maturity, because you have to terminate the pregnancy as she is having headache and blurring of vision. So simultaneously magnesium sulfate as well, we can give steroids also.
Yes, yes, Dr. Mananmani. That can again this magnesium sulfate will be a neuroprotection
also, yeah.
Baby. So it has to be continued every 4 hours, right side and the left side, as Meena told, until the 24 hours after the last fit or 24 hours after delivery. Sadhana, are you going to continue the pregnancy or going to deliver?
This woman, since she has persistent headache, we would like to interfere and her delivery plans can be managed. So as ma'am said, steroids, administration of antenatal corticosteroids should also be enhanced. And along with it, since magnesium sulfate has been administered, we can formulate a plan of management so that we can deliver her.
Okay. So after, as you all told, before the each dose, you have to see the respiratory rate, patellar reflex and urinary output. If the urinary output is reduced, what will you do, Sadhana? If respiratory rate or patellar reflex, if something is a problem. So 8 o'clock you have given the 5 gram IM. So 12 o'clock you have to give, that time output is only 10 ml.
The next dose should be skipped, and
if respiratory rate is increased, what will you do? Patellar reflex absent, what will you do? See, as all of you told, this is the same thing. If the output is reduced, you are going to skip the 12 o'clock dose, and after 4 o'clock again you have to see, and if the output is good means you are going to continue. If respiratory problem means you go with the assisted ventilations, and if needed, you can go with the antidote of calcium gluconate.
Calcium gluconate 1 gram IV.
So 10 ml of 10% solutions you can give. There is no side effect with the calcium gluconate. So Pritchard regimen, all of you should teach your house agents and PGs. You should be very careful. It is the life-saving drug. So as Sadhana, are you going to go for a normal delivery or LSCS?
Yes, depending upon the situation, whether a trial of labor can be given, and if the baby is is not growth restricted and Dopplers are well there, and if it's corresponding to the growth, we can give a trial of labor by inducing her with prostaglandin E2 gel. And if she progresses well, we can give her a normal labor.
So 32 weeks, if the Bishop score is good and induction is good, you can go. Manonmani madam, do you want to differ for LSCS or normal delivery?
No, madam. No difference of opinion. So it is only obstetric indication if she is not progressing or if it is not under control. If she deteriorates, we can plan for section. Otherwise, cesarean is not a straight indication for this severe preeclampsia or severe fetus.
Yes, for preeclampsia, there is not necessary. Meena, do you want to go for an observation for 1 more week or 2 more weeks?
In the sector where we are practicing, so if the symptoms settle, we do prolong the pregnancy, and we do have a multidisciplinary team involving the anesthetist and keeping the high dependency unit ready, and the neonatologist. If the neonatologist we are given the lung maturity dose of steroids, discussing with them, we do continue the pregnancy for 24 to 48 hours, and then based on the Bishop score, we induce the women.
A maximum of 1 week, if needed, you can continue. When we was working in this also, for 1 week, if needed, if the symptoms has reduced, and careful monitoring, 24 hours monitoring is very, very important. Okay.
And also checking the lab parameters, the hematological parameters, the complete
everything should be continuously monitored, BP and the output. Okay. So this was the Pritchard regimen and Sussman regimen. We have told delivery. So as all of you told, after 34 weeks, depending on the severity, you can go for delivery. If it is a severe preeclampsia with complications, better to go for the delivery. Okay. So gestational hypertension, you can wait till 40 weeks. If it is a preeclampsia, even if it is 32 weeks, give magnesium sulfate, steroids, and see the patient conditions and terminate. As far as PIH is concerned, we are bothered only about the mother. Baby, if it is good, it's well. Otherwise, you have, even if it is 28 weeks, we have to terminate if it is a progressing. Yes, so these are all the alarming signs which we are going to do daily, NST, CD. If everything is normal, means twice a week or alternate days also, you can do the steroids. Yes, we will go with the third case. Manonmani madam, you can take up this case. 37 years old, 32 weeks gestation, the same patient. She is on antihypertensive drugs and she is having the routine checkup. She is coming for routine checkup with levodopa 1 TDS. When you are seeing the patient is throwing fits. Eclampsia.
Okay.
It under control, but fits.
Thank you, Sambat ma'am, and thank you, Radha ma'am, for giving me this opportunity. It is a very wonderful CME today, going on as hybrid CME. So everybody is getting utilized with this, all the topics. So this patient coming to routine BP checkup, throwing fit. So she's had eclampsia. So we have to go in for eclampsia drill. For this, we don't see eclampsia in all places. But then we have to have the eclampsia drill whenever we are teaching postgraduates or we are our undergraduates as well, because on the PHCs, even our staff nurses and VHNs are all given training in the BMONG. If eclampsia comes, what is to be done? So they may not be treating the eclampsia at the PHC, but they have to resuscitate and send the patient. So first you have to call for help. Whoever is available with us at that time, you have to call for help and see for the ABCD. Yeah. First is airway. Patient is to be put in the, don't make the patient stand or help the patient to sit up. The patient has to be, if she has thrown a fit on the floor, we can as well put her stretcher on the floor and put in the left lateral position till the stretcher comes, and suction and oxygen. Immediately we shift them to the place where suction oxygen is available. So always first is airway and look for the breathing. If possible, we can, or if you are well versed in using our tongue, we can put the tongue, so it shouldn't fall back and obstruct the airway. And circulation, always have IV access. Have a green Venflon with us. So green Venflon, always start the line above the level of diaphragm. Don't start the line. This thing, whenever at least 1 or 2 persons are available. So one person can start the line and take the blood for all the lab investigations. And the other person, as already PPH kit, Dr. Priyankur was highlighting, the same way, all the hospitals, whether it is a small setup or a big setup, always we should have an eclampsia tray also, which should have a ambu bag as well as knee hammer, but the drugs, as we need to start with, as already discussed in the Pritchard or Zuspan, first loading dose, we need 14 grams. So that 14 grams, 14 ampules minimum should be ready, because sometimes, and ideally, if you have 20 ampules, well and good, or at least 14 ampules should be ready, because in our haste and in attention, we might drop 1 or 2 ampules on the floor. So always the eclampsia kit should have minimum 14 to maximum 20 ampules, so that first dose we can give. And we should have, as already discussed, distilled water, 20 ml syringe, urobag, catheter. So we call for help and somebody put the suction, staff nurse puts the suction, whoever is available puts the suction, start the oxygen, catheterize the patient, put a venflon, take blood. As the same venflon, we can give the loading dose of magnesium sulfate. Even in the, and we have to start with the drugs. One thing I would like to say everyone, so if you're, even if you're in a very small setup, if the patient comes with fit, don't push the patient to the other hospital. This is what has been told everybody. You give the first loading dose of magnesium sulfate, nothing will happen. Even if the urine output is less, as already discussed, nothing is going to harm the patient. But with sending the patient without magnesium sulfate, by the time she reaches the next hospital, her condition will worsen. So always start a line above the diaphragm, that is in the arms. It is good if we can get 2 lines, or at least 1 line we can get, and put the magnesium sulfate. Once the magnesium sulfate is over, you can start them with ringer lactate. The dose should be 60 ml average per hour. Then we can shift the patient if we don't have the facility. So always remember ABC, circulation access and drugs. If you have to see the BP, if the BP is very high, you can go with the labetalol. As discussed again previously, it is only a recap. Labetalol 20 milligram IV, slowly give. You do check the BP after 10 minutes. If it is high again, you give again 40 milligram, double the dose, 40. And again check the BP after 10 minutes, you give again 80 milligrams. Such a way, within an hour, we can go maximum up to 220 milligram as per Government of India guideline. For the PG sake, ACOG gives, you can go up to even 300 milligrams. So this is our labetalol dose. Suppose the patient, you don't have the labetalol IV. You can give even nifedipine tablets. You give 10 milligrams stat. Here you take the BP after 20 minutes. Suppose you are, by the time you resuscitate the patient, by the time 108 or any ambulance come, take a BP after 20 minutes. If the BP doesn't come down, our BP range should be 150-100. So in a hurry, don't bring down the BP very low to the 180 or 110-70. You see to that the BP is maintained at least 150-100, because suddenly drastically reducing the BP again will have a problem with the cerebral circulation. Patient might go on for any bleed in the cerebral bleed. So always you see to that all your labetalol and nifedipine dosage should be, the BP range should be 150-100. For the nifedipine, you can take a BP after 20 minutes. If it doesn't come down, you can add 1 more 10 milligram. So like that, within an hour, we can give up to 40 to 60 milligram of nifedipine. This is even endorsed by ACOG. If you don't have labetalol IV injection, or if the person is not well versed in giving IV labetalol, even our healthcare workers, staff nurses can give nifedipine. So it is again endorsed, so there is no harm in using.
So patient is unconscious, no,
You can give it through Riles tube,
yes.
madam. Yeah,
Riles
you can
tube.
give it through Riles tube also.
Riles
So at this
tube.
point, if everybody remembers, especially in a small places where we don't have ICU setup, so we can give nifedipine without any fear. So labetalol is drug of choice. If labetalol is not available, or if you are not able to give, you can even go with the nifedipine.
Yes.
So again, we have to deliver, because preeclampsia, the baby is the problem. So we have to deliver the baby so that eclampsia settles down. Here, if after stabilizing the patient, then you'll go for the ultrasound and fetal fetch and look for the cervical status. If it is highly favorable, I can put a Foley and keep a gel. They wait for 6 to 12 hours. If she progresses, okay, well and good. Or else if there is a fetal distress, or with associated high BP, she has gone in for abruption and it is very unfavorable, we can go for a cesarean section. preferably we can do to the general anesthesia so that we can support her with elective ventilation. This is what we have been doing. So eclampsia, I would like everyone to remember, if the patient throws fit and lands up in our hospital, please give magnesium sulfate and then send the patient. Don't send the patient in a hurry. This one point, if everyone can remember, it's well and good.
Dr. Meena, would you accept that Foley's induction for an eclampsia patient? Do you go in your hospital?
Yes, ma'am. If the BP is controlled and patient is stabilized, we do give Foley induction, and we do try Serviprime gel, and also with consent, the misoprostol induction.
So the take-home message is, even if it is an eclampsia patient and if it is stabilized, as Madam told, with the right tube, you have to give stabilize the patient with the antihypertensive should be controlled, magnesium sulfate should be given, and then do the pervaginal examination. If patient is stable with 24 hours facility, you can give the induction and then proceed for LFS. LFS is always there. So you can try, since you have the 24 hours monitoring, 1 hour side means you can try for a normal delivery. That is the protocol followed throughout Tamil Nadu. Dr. Manonmani, can you tell the complications for the sake of the PGs?
Yeah, complication, first there could be a abruption, and if with the abruption, patient can go for DIC, and along with eclampsia, we can have the HELP syndrome. And as a part and parcel of preeclampsia, we can have acute renal shutdown and liver failure, hemorrhages, and all your cerebral accidents, stroke. And if patient is not resuscitated, they may land up in death also. And because of the hypertension, as you have put up, madam, there will be a cardiovascular morbidity. And again, neonatal complications for the maternal sake, we have to deliver. So irrespective of the gestational age, if you are delivering, baby might go for preterm delivery and all with IUGR. And if the patient has gone eclampsia and she has not recovered, even hypoxic neurological injury can occur. And one more thing, madam, if the patient has repeated convulsions, we can give a load of top-up dose of 2 grams of magnesium sulfate, that is 2 ampules, if she again throws a fit. And
throwing within 2 hours, you can give
2 grams of one more loading dose of magnesium sulfate. So patient again recurrence in the next pregnancy is very high, and we have to tell them to come for the early checkup and proper monitoring. So recurrence rate should also be counseled for the patient, and long run they can have hypertension in their future in the older age. So they have to be careful for that also.
Thank you, ma'am.
Thank you.
So we have discussed. Yes, Meena.
Those complications can occur 2 weeks prior to the complications which has happened in the prior pregnancy.
Yes,
so need to monitor
in 32 weeks. Next pregnancy is 28.
Yes, madam. There is a question, madam, in the chat box. Nitya Srinivasan has asked if there is any role for nifedipine patch in eclampsia. As of now, we have not used nifedipine patch. Only oral tablets we have been giving. So this is no idea on this. We are not.
I have also not used. Nifedipine patch is not available. I think we have not used. Maybe in abroad. So we will go with the next case. 34 years old, gravida 2, P1L1, 32 weeks again on tablet labetalol and nifedipine. And patient comes to the OP with a history of epigastric pain. On examination, BP is normal. Dr. Karpagambal, are you there? Can you take up this case?
Yes, madam. Yes. From the history, like 34 years, 32 weeks, she's on both 2 medications and who complains of the epigastric pain. Even though the BP is normal, I will be very concerned about this patient. I will admit her, and then epigastric pain, my mind will think more in terms of either a HELP syndrome or a hepatic injury, like either hematoma or an infarct. So most commonly we see, even though the BP is normal, we have seen quite a few patients under controlled blood pressure also can develop HELP syndrome.
So that is the reason. Whether it is in 2 tablets also, if epigastric pain, don't tell that you take antacid or like that.
Yes.
So how are you going to proceed with this patient, Karpagambal?
Definitely admit this patient, madam. And we do all the PH profile as I already mentioned, CBC, LFT, RFT. I also would like to do another investigation called as LDH, which is a very important marker for hemolysis. And LFT, there can be elevated SGOT and SGPT. In this case, we go more in case of ALT, which is ALT is very specific for the liver. So ALT can be raised, and platelets. So the HELP syndrome, the combination is hemolysis, for which we do LDH, elevated liver enzymes, SGOT and SGPT can be elevated. They can be more than 40 or 70 international units per liter, and platelets, which is also a very important marker. So in this case, the platelet is only 40,000. So she comes under a very severe category of HELP syndrome. So we have to admit her in the ICU. She will not go to the ward. She will be only in the ICU, where she'll be monitored continuously, and there can be spontaneous bleeds from anywhere in the IV lines, and there can be nasal bleeds, and there can be bleeds even while we have to catheterize her, and there can be hematuria also. So the first important thing is stabilize the mother, make sure her initial parameters are normal, and then when the platelets counts are reducing, it's important to, best thing is to deliver. The delivery is going to treat the HELP syndrome. So even though she is 32 weeks, travel to para 34 weeks, I think we still can consider giving steroids by the time we stabilize the mother and consider delivering her. And now platelets is 40.
Transfusion platelets, do you want to give?
Transfusion. There are very strict indications for, criteria for platelet transfusion in this. So all of our anesthetists are very comfortable giving anesthesia with the platelet epidural or spinal with the platelet to 75,000. And for a normal delivery, the platelets can be, normal delivery can be attempted. The platelet count is around 25 to 30,000. So because this lady has 40,000, there can be a falling trend. So we have to be very careful. We have to inform the blood bank, make sure the platelets are arranged before we start the induction process.
So what is the mode of delivery, Karpagambal? Are you going for LSCS or normal?
See, if it's a previous cesarean section, I wouldn't even hesitate, madam. I will do a repeat cesarean section immediately.
It's not a previous LSCS.
Yeah, because it's a previous normal delivery, I would assess the Bishop score, and then in fact, normal delivery more favorable for her in terms of with the slow platelets. So I would still consider giving a nice induction process by the time stabilizing her in the ICU.
But not more time. So
yes.
With the transfusion and
it's a slow process. So slow process, and platelets is around 40,000. So 40,000, we can give her normal delivery.
So as all of us told, you have to give the blood transfusions, continuous monitoring, magnesium sulfate, steroids, and blood pressure medications. So since I mentioned specifically, I told we saw one patient with BP was normal with the 2 drugs, but LFT, platelets, LFT was 80 and platelets was normal. In that case, as early as possible, you have to deliver. So that HELP syndrome is a very dangerous complications with the hypertensive disorder complicating pregnancy. Thank you, Dr. Karpagambal. This is the last case, I think. 27 years old, gravida 2 P1, delivered at 40 weeks. She was on labetalol 100 milligram, and 4 days after delivery, she developed a headache and blurring of vision, and she had fits at home. Normally, our patients fit. So when you examine, the BP was 160 by 100. So how are you going to proceed with this? Dr. Sadhana Romanerama Mediaka. Dr. Sadhana.
Yes, this case has been, she has been delivered at 40 weeks and she had fits at home, and now her BP is about 160, 100. So this is a case of postpartum eclampsia. We label her as postpartum eclampsia, and we manage her, and we admit her in an ICU setup.
Sadhana, one point. Since she has delivered at 40 weeks, she is only a case of gestational hypertension. So even the gestational hypertension can go for this all alarming symptoms.
Yes, she is a case of GHD, and superimposed, she has developed a postpartum eclampsia, and we manage this case similar to eclampsia. We admit her in ICU. We manage airway, breathing, circulation. Everything is being monitored, and we control the antihypertensives are being given to control the BP and magnesium sulfate. Similarly, we give them both IV and continuous doses. We administer magnesium sulfate. Followed by it, we plan an MRI. Since this woman has developed headache and blurring of vision, we plan an MRI once she gets stabilized.
So MRI, would you shift the patient? When will you shift the patient? Immediately or after?
Once she gets stabilized, we shift the patient. Usually we shift the patient once everything gets stabilized. We plan an MRI to rule out press.
So how are you going to proceed with this
So
patient?
PRES is, as the name says, PRES is posterior reversible encephalopathy syndrome. It's a transient condition. So usually we have convulsions, visual disturbances, and headache. There are cortical changes alone. It is actually by cortical changes on MRI. But subcortical and chiral hyperintensities are seen. Usually diffuse hyperintensities are seen. So it's usually a transient condition, gets resolved within a week. So the management will be similar to that of as we manage
Normal.
a postpartum case, normal case. We observe the women, and in an HDU or an ICU, depending upon the situation, we manage the women, and usually it gets resolved. All headache and blurring of vision usually resolves. The women goes home happily.
So this patients, we are going that MRI and PRES, it is treatment is same. Antihypertensive, magnesium sulfate, and then say repeat the MRI and it is almost normal. So it is a reversible case. So as Dr. Manonmani told, the PIH kit should be kept everywhere. That should be in the casualty, that should be in the labor ward, that should be in the theater, that should be even in the antenatal ward also. Sometimes in the ward itself, she can go for fits. This PIH kit should be maintained. Magnesium sulfate 16 ampules. In the tension, you will break 1 or 2 ampules, gloves, knee hammer, 20 ml syringe for IV, 10 ml syringe for IM, IV fluids, IV set, calcium gluconate, labetalol, lignocaine. See, now we are taking 10 ml, no? So you can add even 1 ml of lignocaine to reduce the pain and 2 ml syringe. This kit should be kept everywhere. So I think wonderful panelists for wonderful discussions of the PIH cases. The take-home message is monitor the BP. BP monitoring is very, very important. Don't see BP in the patient when it is standing. See the patient in the sitting posture, all in the left lateral posture, even in the heavy OP is very crowded also. Make the patient comfortable and then see the BP. BP itself is the most important thing. During the second trimester, early second trimester, 20 weeks, there will be a fall in BP. But when we see the antenatal cord in all patients, it will be starting from 120/80 to till fifth, it is 120/80. And the 18 to 20 weeks or fall irkad. So the BP monitoring is very important rather than with the Doppler. And the look for alarming signs. Headache, blurring of vision, upper epigastric pain, reduced urinary output, and fetal movement. Start the antihypertensive. The labetalol is the drug. Alpha methyl-dopa is a slow action drug. So nowadays, mostly we are not using. If that is pre-eclampsia and eclampsia, magnesium sulfate, full dose should be given. Even when you refer the case, as Dr. Manonmani told, IV and IM, 4 gram plus 10 grams should be given. Documentation, whatever you have given, steroids given, magnesium sulfate given, labetalol infusion, everything documentation. Priyankur was telling about documentation. Nowadays, ethics, we should, medical legal issues are a lot. So always documentation is very, very important. Call for help. So identify the case earlier and refer. If it is a teaching institute, so the needed cases, whatever it is. So once again, I thank
Madam, shall I add
Yes.
one more point?
Yes,
Madam,
Manonmani.
actually, I would like to highlight many a times in a small hospitals when a nurse is seeing with the epigastric pain, they think it is a gastritis, and you have
Yes.
received 2 or 3 patients with the same complaint after 24 hours with the epieclampsia. So this should be like told everybody, because with the PHC, they are identifying correctly and sending, but a small nursing homes, when they are not tuned to this, they think the epigastric pain is gastritis and ranitidine given or pantoprazole given, and in the morning they come with convulsions. This is one thing. And some doctors in the video conference, we have been hearing that they are not aware of the magnesium sulfate regimen,
Yes.
and they are not giving magnesium sulfate. Those who have done a post-graduation in the last 15 years, they are very well aware of magnesium sulfate now to give. But those who have passed out before and practicing, I think they should be given this, how it should be used, and as like a VHNs, out of the protocol chart, so that they don't miss it. And one more thing is, as Priyankur said, all the PIH kit, eclampsia kit also, they have to daily check and see the expiry drugs, because it is there in the Lakshya protocol. The same way they can check daily. So these things I would like to add, madam. Thank you so much for your.
Yes, madam. If you do this, we can be free. So the maternal mortality also will be reduced. So once again, I thank all of you for the wonderful discussion. And thank you, Dr. Radha and the team.
Thank you, Radha ma'am. Hi,
Thank you.
Thank you.
Thank you, Dr. Anjalakshi, Sampath ma'am, Priyankur Roy sir, Manonmani ma'am.
Meena ma'am, Sadhana ma'am, Karpa Ammal ma'am, and last but not the least, Sanfama for letting me organize this meeting, which is both online and offline. Thank you all for logging in and hope it helps our patients. Thanks a lot.
Thank you, madam.
Thanks, Radha.
Thank you.
திருவண்ணாமலையில PIH PPH வராது, மாசம் ப்ரோக்ராம் பண்ணிட்டே
நான் யூஸ் பண்ணிட்டு தான் இருக்கேன்.
Madam, doctor has asked, sorry, madam, one question has asked in the chat box. What about low molecular weight heparin and PIH in eclampsia patient? So basically,
they are not giving unless
we are not giving, no, unless
proven APLA or
exactly. We should not be giving because it's always double-edged sword. So we can't just take that give in a patient with pre-eclampsia and eclampsia. This thing. So they are at risk of DIC anytime. So without knowing the factor that we cannot give them low molecular heparin just because they have thrombotic events. And so Nitya madam asked about nifedipine patch. Actually, nifedipine patch is not actually that much. There is no much evidence for nifedipine patch. Even sublingual nifedipine is not recommended. It's only the oral nifedipine which is actually quite effective these days. So quite effectively reduce the blood pressure. So we don't use nifedipine patches at all, madam.
Yes. சரி, பிரியங்கா ஒரு நாளைக்கு அண்ணாமலை யார பாத்துருங்க, நானும் கேட்டதா சொல்லுங்க.
Definitely. போற மேம் நாளைக்கு காலையில பிளான் பண்ணிருக்காரு மேடம் சார்.
Yes, you can go for கிரிவலம்.
ஆமா.
மேடம் திருக்கோயிலூர் கூட போறோம்.
போயிட்டு வாங்க. பச்சை கலர்
சண்டே ஈவினிங் நல்ல ஹைபிரிட் CME சக்சஸ்.
Fantastic. Thank you.
Many mad. Super. Thank you.
Thank you so much.
Thank you.
Thank you.
Good night.
Thank you so much. Thank you.
Thank you, Priya. Thank you. Priya, Stevens.
Thanks, ma'am. Thanks, ma'am.
Hey, Priya, thank you.
Thanks, ma'am.
Well coordinated. Thank you, Priya. Thank
Thanks,
you.
ma'am.
Yes,
Thank you.
Super.
Last month madam கிரிவலம் போயிட்டு வந்தனால
இந்த வாட்டி வாங்க வரும்போது.
கண்டிப்பா மேடம், கண்டிப்பா வரேன். நான் வந்து ஆக்சுவலி ஒரு மாரத்தான் ரன்னிங் குரூப்ல இருக்கேன். பட் நான் வந்து 2 கிலோமீட்டர்ஸ்ல முடிச்சிட்டேன். நான் 14 கிலோமீட்டர்ஸ்
2 ஹவர்ஸ்ல முடிச்சிட்டீங்களா?
2 ஹவர்ஸ்ல முடிச்சிட்டேன் மேடம்.
நல்ல எக்ஸ்பீரியன்ஸா இருந்திருக்குமே.
ரொம்ப பிடிச்சது மேடம், ரொம்ப நல்லா இருந்தது.
திருவண்ணாமலையா?
5:30க்கு ஆரம்பிச்சேன், 7:30க்கு முடிச்சிட்டேன்.
எக்ஸலென்ட் எக்ஸலென்ட்.
மேடம் உங்களை பத்தி தான் பேசிட்டு இருந்தோம் மேடம் எல்லாரும். மேம் எந்த அளவுக்கு ஆக்டிவா இருக்கீங்க சோஷியல் மீடியால எல்லாரும் உங்களை ஃபாலோ
இன்னைக்கு காலையில கூட DRHM மேடம், இன்னைக்கு ஒரு ட்ரீம் ரன்னர்ஸ் ஹாஃப் மாரத்தான் 10K ஓடிட்டு வந்தனால.
நெக்ஸ்ட் டைம் வாங்க, நான் வந்து நடந்துறேன், நீங்க மாரத்தான் ஓடுங்க.
நடந்தேன் மேடம், பட் இட்ஸ் நைஸ் சீனரிஸ். ஐ லைக் இட் வெரி மச். நெக்ஸ்ட் டைம் திருவண்ணாமலை வரும்போது வரேன் மேடம்.
சரி வாங்க. Thank you மேம்.
Thank you, madam. Thank you, Dr. Priyanka. Thank you, Radha madam. Thank you, Sampath madam, Anjalakshi madam, everyone. Thank you and good night.
Good night. Thank you.
Bye.